Ladies and gentlemen, good afternoon. This is yet another webinar that Thalassaemia International Federation is organizing in the context of its educational program, and more particularly in the context of its electronic platform for healthcare professionals. I have the pleasure and great honor to welcome Professor Konstantina Politis from Greece, a great friend first and above all, and an invaluable collaborator throughout the years since the establishment of Thalassaemia International Federation, an expert in blood and blood transfusion at the national and international level, and an author of many books and published reports. Thank you very much, dear Konstantina Politis, for being with us, for being always in the panel of advisors of Thalassaemia International Federation. And we'll be very interested to hear you out what has been happening, what is happening at present, and what can we expect in the future with regards to safeguarding the safety of blood. At the same time, I'm truly honored and very privileged to introduce a consultant hematologist from Whittington Hospital, a great friend, Dr. Shah. Thank you, Farah, for being with us. She's always, as well, being amongst the Chiefs Advisory Panel since the early years, and a great teacher, a great friend of our thalassemia patients, not only in the United Kingdom, but all over the world. She's been with us in delegation visits across the world. And thank each and every one of the healthcare professionals that have registered to follow this webinar, which will be videoed and will be uploaded immediately after, with the consensus and permission of our two speakers, on our website and on the healthcare professionals platform. So, this is from me, and straight away I go to Professor Konstantina Politis, who's at the moment head of the Coordinating Hemoregional Center and Surveillance of Transfusion in Greece, but she has had numerous posts, leading posts in Greece with regard to blood and blood transfusion. Professor Politis, the floor is yours.
Thank you very much, Andrew. It is a great pleasure for me, and also it's a great honor to be with you in this webinar. It has been a lifetime cooperation with people working for TIF and many other colleagues. And indeed, I hope that I shall try really today to share with you some information about blood transfusion and new developments. Just a moment, please. I'm trying to start moving with my slides. I beg your pardon. So now I will start really with something that everybody knows, that the targets of blood transfusion are safety, quality, and adequacy. In this presentation, I shall try to provide a brief general information about the thalassemias, as well as for safeguarding blood safety in a global perspective. And in the end, I shall try to give you some of our Greek experience in ensuring safety and availability of blood for thalassemia patients. So, the thalassemias constitute a group of hereditary anemias characterized by a deficiency that affects the hemoglobin synthesis of one or more of its own globin subunits, that they are affecting the alpha and beta globin chain ratio imbalance. As regards the clinical spectrum, we have two big categories. thalassemia, transfusion dependent, and non-transfusion dependent thalassemia. Now, we know that the goals of transfusion therapy in this hemoglobinopathy which is the cornerstone of treatment, are use of donor red cell concentrates with an optimal recovery and half-life in the recipient, achievement of appropriate hemoglobin level in the patient, and last but not least, avoidance of adverse reactions as, for example, secondary iron overload, which can lead to organ damage and failure, especially in the heart, liver, and endocrine glands, as well as other complications, mainly alloimmunization and, again, last but not least, transfusion-transmitted infections. Now, a few words about the global data that WHO is providing us on thalassemias. 1.5% of the population, that makes 80 million, are carriers of beta thalassemia. 60,000 affected children are born annually, while 7% of the population, that makes 266 million people, are carriers of beta thalassemia, sickle cell disease, and hemoglobin E double heterozygote situation with beta thalassemia. TIFF is telling us that 600,000 patients with thalassemia syndromes are recorded to be under treatment. However, these are grossly undetermined data because few countries have national registries and they can provide epidemiological data. Now, what is the global perspective for blood safety? Safety and quality of blood components is a primary focus for everyone involved in transfusion medicine, and for this purpose, the WHO, the Council of Europe, and the European Union have issued recommendations, resolutions, directives, and technical guidelines to ensure safeguarding blood safety and quality. Voluntary, non-remunerated regular blood donation represents the cornerstone of blood safety, ensuring the lowest possible risk of transmitting infections, viral, bacterial, parasitic, and other, thus contributing to the protection of human health. Contamination from blood donors infected with old, as we are calling them, or emerging infectious diseases, are threatening safety and quality of blood. Other threats are deviations from established procedures and errors during blood collection, blood testing, processing, storage, and distribution, as it is beautifully and very clearly stated in the European Union Directive 2000/98. Lack of standardization is also threatening safety and quality of blood. And this is why good practice guidelines for standards and specifications for implementing the quality system in blood establishments have been prepared through an ad hoc cooperation between the EDQM Council of Europe and the Commission of the European Union. In this context, I advise all colleagues who are attending this webinar to be aware of the 20th edition of the Guide to the Preparation, Use and Quality Assurance of Blood Components of the Council of Europe, in accordance with the directives about quality standards for quality, number 2005/62, Article 2, as amended by the Directive 2016/1214. Now, I would like just to give you just an indication of what I mean by standards for blood components. For example, I shall speak a little bit about processing. And what do I mean by processing? Preparation, that means, of the blood components. The premises must be clean and have hygienic conditions. The microbial contamination load on equipment, surfaces, and in the environment of the processing areas should be monitored. Procedures must detail specifications for all materials, additive solutions, bags, and equipment. Now, processes for a specific procedure, very important for the quality and the safety of blood transfusion, particularly for thalassemia patients, is leukocyte depletion. Leukocyte depletion must be validated. I mean, the process must be validated. And as regards the quality control, a validated method for leukocyte counting must be used. Bacterial safety of blood collection and processing procedures must be in place, while storage conditions must be controlled, monitored, and checked. In this context, appropriate alarms should be present and checked as well, while transport and distribution must be carried out under very well-defined conditions. All these are very important issues. A target point for safety and quality of blood is screening for infectious markers that can be transmitted by blood components. Currently, minimum mandatory screening tests, as you all know, are serological methods for hepatitis B, hepatitis C, syphilis, HIV, and in some countries for HCLV1 and 2. While molecular methods, the nucleic acid screening for HCV, HIV, and HBV DNA represent the state of the art in many countries, but not all countries, as you know. Now, a few words about transfusion transmissible communicable diseases. Strategies for suitable donor selection and screening of donor blood include permanent, that is rejection, or temporary, that is suspension, donor deferral, aiming to minimize transmission of infectious agents by transfusion in conditions favorable for communicable diseases outbreaks. Now, the risk of donor exposure to infectious agents and travel history are crucial topics of donor questionnaire and medical interview of donors, particularly for conditions where there is a possibility of asymptomatic infections or existence of a carrier state. Now, another very important issue, epidemiological surveillance of adverse events and adverse reactions in donors and recipients of blood. That is the hemovigilance chapter of safety and quality of blood. For close monitoring throughout the chain from vein to vein, as well as risk-benefit analysis, should be carried out to determine the appropriate measures to decrease the risk of emerging infectious diseases in countries without just such history and when deferral policies may affect blood supply. Now, we have a real problem here with new and emerging infectious agents because basically of the spread of insect vectors through travel and trade, combined with climate change, that they are posing a significant challenge for public health and transfusion medicine in European and other countries. Here, I will just mention malaria, West Nile virus infection, dengue virus, babesiosis, Q fever, the chikungunya virus, Chagas disease are just examples of such infectious diseases. So, donor deferral may not be an option in the newly affected areas. Thus, donation testing is then the main tool to reduce the risk of transmission, but this is not always possible. While pathogen reduction for fresh frozen plasma and platelets may also be considered, but this is not yet the case for pathogen reduction in red cell concentrates, which is the main component used around the world for blood transfusion, and as we all know, also for thalassemia patients' treatment. Now, a few words about the blood-borne diseases, especially malaria. Malaria is one of the most severe public health problems worldwide. It's a leading cause of death in many developing countries, mainly in Africa. And according to the fact sheet of WHO, 207 million cases in 2012 and 27,000 deaths, mostly children, are attributed to malaria infection. Now, what about dengue hemorrhagic fever? So 40% of the world's population is at risk from dengue virus, the world's fastest growing vector-borne disease, with a 30-fold increase in incidence over the last 50 years. Now, about transfusion-transmitted malaria. This is sporadically reported in USA and Europe. Focus on the risk of transmission in travelers to endemic areas and in permanent residents with origin from endemic areas. In the US, most cases could have been prevented if the implicated donors had been deferred according to established guidelines. That has been a statement in the year 2017 from the CDC. In France, in the UK and other countries that are not affected by malaria, they have in recent years changed their travel-related blood donor selection policy because their epidemiological data told them to do so. In Greece, we had a malaria outbreak which started in 2009. An outbreak of locally acquired Plasmodium vivax malaria in my country, that it was picked in 2011, raised the issue of how to define spatial boundaries of affected areas for blood donor deferral in relation to blood safety and sustainability. But the fact that no laboratory test is sufficiently sensitive for reliable detection of low parasitemia in asymptomatic potential blood donors who may have been infected have also raised questions about blood screening strategies. This handsome young man, Tutankhamun, of the 18th dynasty of the Egyptian pharaohs, has provided, his mumia, the most ancient genetic evidence of malaria. He died when he was 18 years of age because of malaria. We know that now. Now, a few epidemiological data for reported malaria cases by year and case classification in Greece over the period 2009 to 2019. As you can see in this table, we have two main categories: the imported cases from immigrants and locally acquired cases. In the imported cases, we have diagnosed P. vivax, P. ovale, as well as falciparum, while in the Greek locally acquired cases, only Plasmodium vivax has been diagnosed. Altogether, with both categories, we have diagnosed 753 cases. And you see on the right-hand side, under the heading locally acquired P. vivax, we have diagnosed 110 cases. But be careful, these are not transfusion-transmitted malaria cases. We had no transfusion-transmitted malaria cases has been diagnosed in Greece over this period. But a few words about the decision-making and the action plan for the management of malaria. For the risk assessment, we have a lot that we have been doing due to the national experts' consensus. We have divided risk levels 0 to 3. And the action plan is focused on enhanced malaria surveillance, including active case detection with focused investigation all over the country, daily door-to-door proactive case detection in high-risk areas, as in the broader area of Laconia, where the outbreak started. 2, enhanced laboratory diagnosis of malaria, case management, that is case classification, place of exposure, place of residence, entomological surveillance and control activities, equi surveillance and communication involving health professionals, public, Ministry of Health, the ECDC and the WHO, as well as blood safety and hemovigilance measures. For all this work, a multi-sectoral, multidisciplinary scientific working group has been appointed for the designation of areas affected by vector-borne diseases. Committee for the Prevention and Management of Tropical Diseases of the Ministry of Health, and an ad hoc advisory group of risk assessment and rapid response for cases introduced or autochthonous of dengue, chikungunya, Zika, and so on, are helping the Ministry of Health in decision-making and action plan for the management of malaria. There is something that I would like really to stress here for the interest of colleagues that they are attending this webinar, the contribution of genotyping of vivax malaria cases in Greece. This genotyping is revealing the specific alleles inherited by an individual, and it detects and characterizes genetic variability, aiming to identify the origin of the strain that caused an epidemic, the pattern of spread, relapses, and current or previous infections. What is the main idea of that? Strains that share more identical markers, that is alleles, are more likely to share a more recent common ancestor. So for P. vivax, one of the most studied genes, the merozoite surface protein 3A is highly polymorphic, while microsatellite markers, as they are called, are also applied in P. vivax genetic diversity studies, increasing analysis of results. And now, about the West Nile virus infection, we know the strain 1 and the strain 2, that it is the case for Greece. We have diagnosed only West Nile virus 2 cases in Greece since 2010 that we had the outbreak. So you will see here that we have so far diagnosed 1,202 cases in the general population in various affected areas. And they are not all with neuroinvasive disease, severe disease. It is the 85.7%, while the mild represents 36.3% of total. And we had many deaths as well. That is 100, the number is 158, and that gives a fatality rate per West Nile neuroinvasive disease, 18.4%. It is really very high indeed. What about now surveillance of donor blood for West Nile virus RNA over the period of time? I don't want to take your time, but we had not many cases. We had 28 cases diagnosed, and that is giving a prevalence of 1 per 12.8 per 10,000 blood donations. Now, in the context of an epidemiological surveillance for all adverse reactions and adverse events in Greece, would like to show you in this transparency the hemovigilance data in the period 2010 up to 2017. I will just give you the rate of all adverse reactions, and here I would like to make a point. While the European Union directive is asking the member states to report the serious adverse reactions in Greece, the Hellenic Coordinating Hemovigilance Center has decided since a long time ago, because we have celebrated more than 25 years since the foundation of this center that is cooperating with our National Blood Center and is reporting to the Ministry of Health in Greece. And we are also providing data for European Union in the Council of Europe as well as in the WHO. We are actually collecting data on all adverse reactions because we feel, as the International Hemovigilance Network is stressing, that the serious ones are the tip of the iceberg. So here we have the transfusion-transmitted adverse reactions due to bacterial infections, as well as viral. Total 25, and that really is making a rate of 68% for the bacterial contribution and 32% for the contribution of the viral infections in this sort of transfusion-transmitted infections for all patients in need of transfusion. Now, I take the opportunity of this webinar to show you some data from the European Union Serious Adverse Events and Reactions exercise divided by specification. Here you can see that serious adverse events per specification are attributed mostly by human error. This is very, very important. By product, not that much. And then you can see in this pie chart, the distribution by equipment failure and other causes. And on the right-hand side, in the table, you can see the deviation by blood defect, equipment failure, human error, and other. So it is the human error that matters in this situation, and that is really a great lesson that we have learned. And I here would like to pay tribute to the contribution in the international hemovigilance of the Shah, the British excellent system that we are all admiring and try to be equals with them. And we have now a few more things to tell you about the international situation that is not that great as it is in European countries. Because as you will see, WHO has really investigated in which countries at least 30% percent globally, they do have a national blood hemovigilance system. In Europe, 77% of the countries, not European Union. In European Union, there is a law, but all Europe. In Southeast Asia, 46% of the countries. In Eastern Mediterranean, 35%. In the Americas, all Americas, only 14%. And in Africa, 26%, while in the West Pacific, it is 32% of these countries do have hemovigilance systems. Now, let's come back to Greece, which is a country affected by thalassemia. We have spoken about blood safety and a little bit about quality prerequisites, but blood availability is a very, very big issue. And here in this pie chart, you see that in Greece, 20% of the total blood supply is for thalassaemic patients who are suffering from the various syndromes. And now a few epidemiological data concerning the seroprevalence of transfusion-transmitted infections in 1,315 patients with thalassemia and sickle cell thalassemia over the period 2010 to 2017. The Australian antigen, 1.8%, anti-HCV, 54%, anti-HIV, 0.3%, anti-HTLV, 0.8%. We have also tested patients for anti-West Nile virus antibodies, 0.5%, and recently for anti-hepatitis E virus, 3%. Well, of course, the hepatitis B, hepatitis C, and now HIV and HTLV are all infections, while West Nile virus infection and hepatitis hepatitis E virus infection are classified under the heading of the emerging infectious diseases. Somebody at this moment that the world is suffering from the pandemic of COVID-19 would make a question. Okay, we would like to hear something more about COVID-19. Is it transmitted by blood transfusion? Up to now, there is no evidence of such thing. And this is the case for SARS-2-CoV. That is also the case for all respiratory viruses. So at least we have something good from this side. Only theoretical can be said that it is considered the transfusion-transmitted COVID-19. No evidence up to now. I'm saying that twice, 3 times. We had recently an investigation in 1,788 thalassaemic patients for the prevalence of anti-SARS-2-CoV. And I'm very pleased to say that 0.33% of patients were positive for these antibodies, but no thalassaemic patient has presented and reported with any symptomatic COVID-19. So this is good news, really, for thalassemia. As regards now the immunization, which has been an enemy, a threat for the safety and the quality of blood transfusion for thalassemia patients, thalassemia major, thalassemia intermediate, eThalED, and sickle cell disease. And here, in a study, we have published it. You can see the reference. Before the 2010, we had seen that 13% of the patients were presenting with alloantibodies, but after the 2010, that took some stringent measures for antigen matching strategies, the frequency of alloantibodies, of new alloantibodies, fell into 1.4% of tested patients. Now, I think it's time to talk about factors for transfusion transmitted in the recipient. Are they all recipients vulnerable for transfusion transmitted infections? Actually, it is believed actually that, and it's claimed rather, I would say that the frequency with which an infection is transmitted depends on the length of the asymptomatic blood-borne period, how often blood is donated during this period, and the immune status of the recipient population. So this is really very much interesting for thalassemia. It's an information that it is really interesting to be further discussed and investigated. Factors now relating to the infectious agent and to the genetic and immunologic makeup of the recipient will also determine the frequency and severity of the disease resulting from the infection. So in conclusion, risks and threats will always continue to exist. Scientists know that very well. But laboratory tests may fail to identify viruses during the window period or because of imperfect sensitivity. The clinical significance of newly identified infectious agents is not always completely clear, and donors are not screened for these agents. Newly emerging infectious agents such as coronaviruses, highly virulent influenza strains, prions, and others may constitute serious threats, at least theoretically. Absence of widely accepted or routinely used tests for bacterial, viral, and other pathogens, for example, Yersinia enterocolitica, hepatitis A, toxoplasmosis, malaria, and babesiosis. So I think before I thank you, I just would like to show you the poster and a leaflet, the picture of the leaflet in English as well as in Greek that we have distributed to our population in the context of the strategies in order to make people in this moment of the pandemic to come and donate blood so that we could have adequacy for the blood supply for all patients, all emergencies, as well as for thalassaemia patients. Thank you very much for your attention, and I'm here to answer, if I may, any of your questions. Thank you very much.
Thank you very much, Professor Politis. It has been a very comprehensive and informative description of what we mean by blood safety in the context of thalassemia. As we know, blood safety is the cornerstone of the management. And I think that with your permission, we can go straight to our second eminent speaker, Dr. Shah, and then we can receive and answer some of the questions that we have already received. So Farah, the floor is yours, and thank you for your patience and your time.
I'm going to basically cover transfusion and why we decide to transfuse individual patients, and then I'm going to talk a little bit about complicated transfusion patients. So first of all, the patients that we transfuse with thalassemia syndromes are basically the transfusion-dependent thalassemia. We intermittently transfuse patients with non-transfusion dependent thalassemia, and we also can transfuse some patients with alpha thalassemia syndrome. So hemoglobin Bart's alpha thalassemia 0 patients all need blood transfusion from fetal life for for survival. But the severe HBH patients, certainly in my experience, the ones which tend to run quite low hemoglobins often end up needing intermittent transfusions. And as they get older, certainly as they get into their 40s and 50s, some of those HBH patients actually end up needing regular blood transfusions. So what are the goals for transfusion? Well, the main goal is to really to control the severity of the anemia to prevent complications from happening. And controlling hypoxemia and reducing the bone marrow hyperplasia are very important roles of blood transfusion. But also, we don't want to just transfuse our patients. We want to make sure that our patients are functional and have a good quality of life as a result of the blood transfusions. Something that is half done doesn't give you the best benefit. So we want to prevent bony complications, ensure that our patients have good quality of life, and we want to avoid splenomegaly and hypersplenism. So the differences between thalassemia, one of the hardest things that I find is In the Thal major patients, it's easy. You know that you need to transfuse and you go ahead. But there are a spectrum of patients who are very difficult from a decision-making perspective around whether we transfuse them or whether we can hold off transfusing them. Most of the transfusion-dependent thalassemia patients will invariably have started blood transfusion by the age of 2. They do have very severe hemoglobins between 60 and 70 grams per litre in the new measurements, or 6 or 7 grams per litre in the older measurements. They often have very high hemoglobin Fs, and they have severe splenomegaly at presentation, especially if they've presented late. In our situation, our patients invariably, we know that they have thalassemia major very soon after birth because of the newborn screening programs. So our children do not present with either severe anemia or with severe hepatosplenomegaly, but this is the common situation globally. The non-transfusion dependent thalassemia patients are more difficult. In particular, the E-beta thalassemia patients are very difficult. So they can present much later on, certainly above the age of 2. They may have anywhere between mild and severe anemia, and we have we have patients with hemoglobin E-beta thalassemia who run hemoglobins of 65 to 70 who are functionally very well, who don't present with features of marked anemia. And so it can be a very difficult decision as to whether you transfuse those patients or not. And patients, if they don't have, they can present with mild to severe splenomegaly and hepatomegaly. And so that all makes the situation very complicated. So we have patients, this is a classical description of patients with E-beta thalassemia. And what you can see in the picture is a very varied spectrum of children who look completely normal and children who look very markedly thalassemic. What we do know from more recent data that's been published is that the quality of life of people who live with very severe anemia, in particular E-beta thalassemia, with low hemoglobins, the quality of life is significantly worse than those patients who are not, who are on regular blood transfusions. So living with chronic anemia severely impacts on your overall quality of life. And what we know is that if you start some of these children off on regular blood transfusions, their growth and development is very good. And if you give them intermittent transfusions, their growth and development is often very poor, and they are severely impacted on by that anemia. Ali Tahir's group study on the optimal care cohort basically showed that blood transfusion gave health advantages to patients. So people who were being regularly transfused, as you can see from here, had a lower risk of developing extramedullary hematopoiesis, a lower risk of developing pulmonary hypertension or heart failure from the anemia. They were also significantly less thrombotic, and they were less likely to develop leg ulcers. Transfusion, however, does have its disadvantages, and one of the things that Ali Tahir's study identified was the fact that being on regular transfusions increased your incidence of developing hypogonadism and also bony problems such as osteoporosis. However, you are actually preventing a huge swathe of problems which are a real issue in people who are not on regular blood transfusions. This is one of my patients. She has beta thalassemia intermedia. She was transferred over to hydroxycarbamide when she was a young girl, and she presented to me with a cough. And I think this is a really important thing for everyone to remember. She had a hemoglobin of 90 on hydroxycarbamide, and the cough was really impacting on her quality of life, and she felt like she was suffocating intermittently. We did an MRI scan, and what you can see here is this very dramatic extramedullary hematopoiesis. She's got an extramedullary hematopoietic mass here. She's got extramedullary hematopoietic masses here with a hemoglobin of 90 and a spleen which is as big as her liver. So what do you do in these patients? It's very, very difficult to make the right decision in these patients because they have good hemoglobins, or what we would class as relatively good hemoglobins, but they are severely impacted by extramedullary bone marrow expansion. In the non-transfusion dependent thalassemias, the main indications for blood transfusions were to cover periods of intercurrent infection, pregnancy and surgery, and that was primarily driven around giving people a good hemoglobin so that they could handle the stress associated with that circumstance better. I think my own personal, I am a transfusionist. I prefer to transfuse my patients because I personally think that in the UK, the blood supply is very safe, and the quality of life and the health outcomes in the thalassemia major patients are much better than those in the thalassemia intermediate patients. And so why would I choose to let my thalassemia intermediate patients suffer? So there has been a shift in our thought processes around transfusion, and the old rule was that if at all possible, avoid blood transfusion. And I think that the new rule is actually very sensible, and basically we should, if we have safety of blood, we should aim to transfuse because we can chelate with oral iron chelators, and you therefore are reducing complications and improving your patient's quality of life. So when do we decide to transfuse? Well, when the hemoglobin is less than 70 grams per litre on 2 occasions, more than 2 weeks apart, is the TIF guidelines for recommendations for transfusion in thalassemia major patients. This doesn't really hold well with the thalassemia intermediate patients, but you can apply the other rules for transfusion, in particular poor growth, impairment of activity, the development of extramedullary hematopoiesis or facial changes as an indicator for initiating blood transfusions in patients with non-transfusion dependent thalassemia. I actually use these criteria in my thalassemia major patients as well, and I will institute blood transfusion earlier if I think that the situation is deteriorating, even with hemoglobins of maybe 80 or thereabouts in my patients. All the guidelines recommend careful monitoring of anemia and clinical symptoms. And I think I have certainly seen patients who have never hit a target of 70, but who have had really very significant extramedullary hematopoiesis or facial changes. And I think that it's very important that as clinicians looking after thalassemia patients, we remember that the patient's health outcomes and facial appearance are actually hugely important. And you do not want your patient looking significantly different to other members of their family or from their peers, because that has a huge psychosocial impact on the long-term emotional well-being of your individual patient. So why is the decision to transfuse so complicated? And I think it's difficult because different doctors have different thresholds for starting blood transfusion. Different patients have different thresholds for wanting or even accepting blood transfusion. And because the availability, the cost and the safety of blood are not the same universally. There are countries where I would say do not transfuse because the blood supply is just not safe enough. Whereas in the UK, I could quite happily go ahead and just transfuse my patients without worrying about the safety of blood. And then you've got patients like this. This is a 54-year-old woman with compound heterozygosity of beta thalassemia. She's got a hemoglobin of 11. Reticulocyte count is 14%, and she has between 300 and 600 nucleated red cells per 100 white cells. So she clearly has very stressed erythropoiesis. However, the stressed erythropoiesis is actually giving her a reasonable hemoglobin, but her quality of life is terrible. She has constant fatigue. She has dental problems, which are really significant. She went through puberty naturally and then developed secondary amenorrhea at the age of 22. And she has a weight of 45 kilos despite multiple attempts to gain weight. So her energy requirement, her metabolic energy requirement is entirely being used in her manufacturing her blood supply. So she's not gaining weight, becoming more feminine in her appearance or anything like that, and is struggling to keep that hemoglobin at 11. She had a splenectomy as a child, and she has a history of pulmonary hypertension and a right atrial thrombus with a normal T2 star, normal LV function, and a liver iron of 11. But that hemoglobin of 11 stops people from thinking about, well, is she actually going to benefit from blood transfusion? And I think that this is a really, really difficult patient to make the right decision on. And I remember Beatrice Wonke telling me when I was working for her as a registrar that any decision you make for a thalassemia intermediate patient is a wrong decision. So whether you choose to transfuse or whether you choose to not transfuse, the decision is wrong in those individual patients. So alloimmunization, so we do have a real problem, as Dr. Dina mentioned, around alloimmunization, and the frequency of alloimmunization in the thalassemia setting is between 4 and 37%. The age at which the individual starts transfusion does impact on alloimmunization, and we certainly see that in the patients who've started transfusions later, they have more problems with alloimmunization. And also, as Dr. Dina said, the extent of antigen matching is really important. So we have matched in the UK for CD and E as well as KEL for many, many years for our patients. And actually we have a relatively low alloimmunization rate. And this is despite the donor population and the recipient population being quite different. So we've got a predominantly Asian and Cypriot thalassemia population, and our donor population is predominantly white Caucasian. So we match for CD, E, and KEL, and it is obviously globally dependent on resources and what is available. So when to transfuse, the rate of alloimmunization, if you transfuse before the age of 1, is 7.7, and if you do it above the age of 1, it goes up. And the later that you start transfusions, the higher the alloimmunization rate. In the thalassemia major patients, and partially in the intermediate patients, once you start transfusions as a preventative therapy, not as a ad hoc, I'm doing it now as an emergency because the patient's got severe anemia following an infection. But when you start it as a maintenance therapy, then you really do need to do it properly. There's no point in doing half measures. So in thalassemia, what we tend to do is we tend to transfuse between 2 and 5 weekly. We aim to have a pre-transfusion hemoglobin threshold of between 90 and 105, or between 9 and 10.5. Certainly in my practice at the Whittington, we tend to transfuse with a hemoglobin of 100 or around about 10. And I don't by and large like it when my patients go to a hemoglobin of 90 or certainly below 90. It's not a desirable goal, certainly in my center. And we aim for a post-transfusion hemoglobin of between 14 and 15 or 140 and 150. We don't monitor the post-transfusion hemoglobins in our patients. So why do I not like it when my patient's hemoglobins fall? This is a thalassemia major patient, and he has kidney stone problems. And we thought when he was complaining of loin to groin pain, it was kidney stones. He'd been very, very busy at work, and he'd let his hemoglobin go down to 80 pre-transfusion on a couple of occasions. So for about 3 months, he was running between 80 and 90 most of the time. And so what we have here is that his spine looks not too bad on that cut. And what you see here is this massive extramedullary hemopoietic mass, which had developed and was causing loin to groin pain in his case. And we had thought it was kidney stones. And the only thing I can say is thank God he went for an MRI scan. He ended up needing radiotherapy to the mass because it was extremely painful. And we also added in hydroxyurea to his transfusion strategy to try and keep that down. And he's now on high intensity transfusion. In fact, I don't let his hemoglobin go below 110 or 11 in the old currency. So just a quick talk about the Whittington Thalassaemia Service. So about more than half of our blood, annual usage of blood, is actually used for our thalassemia patients at the Whittington. We are the largest centre in the UK. During 2017-18, when we did a service load audit, we actually transfused either regularly or intermittently 196 patients. 72 of our patients have got atypical antibodies. One had at that point a very strong autoantibody. And 6 of our patients needed washed cells. 5 of the patients actually had very complex antibodies, and the National Blood Service needed 7 days notice to source blood for those 5 patients. So why do we have this situation? Well, I think the 72 patients, we are, apart from being the largest thalassemia service in the UK, we are blessed with the oldest cohort of patients. Many of our patients were born in the 1950s and 60s, and the majority of our patients only got ABO and RHD matched blood. They certainly are not of a generation where they got CE and KEL matching or other antibody matching. They do now, of course, so they haven't developed new antibodies, but we certainly had that problem in the older cohort. These are our complex antibodies, and what you can see here is that, very interestingly, the bulk of the antibodies for the majority are CD and E cohort or KEL antibodies. So CE and KEL, DE and KEL, and then here you've got KEL, C and E. And then you've got obviously the other antibodies that are prevalent. And our patients get washed cells. Some of them get significant reactions despite our blood being leukodepleted at source, and so they then move on to washed cells. Do I still have a little bit of time to just talk through a quick case, or do you want me to finish here, Andrula?
Yes, please go ahead.
Okay, so this is thank you so much, Andrula. This is a really interesting Thal major case, and basically I'm using him as an example to say that putting patients on blood transfusion isn't always the best, but in his case, he's a transfusion-dependent beta thalassemia major, and he developed a significant autoimmune hemolytic anemia during, with his thalassemia. So this made the situation very, very complicated to manage. And I think it's got some really good learning lessons in there. So this is a Thal major patient, started blood transfusions at the age of 6 months. And as a child, he'd had 1 episode of autoimmune hemolytic anemia where he was treated with prednisolone and cyclosporin. And that had all settled down, and he no longer had any problems with that. He's a patient who has complex antibodies and in fact needs a week's notice to get matched blood for him. So the situation actually became really very, very difficult. He's well, he works full time, he is an insulin dependent diabetic, and he normally gets 4 units of blood every 4 weeks. And he is known to have a panagglutinin with a positive DAT, which has been long standing. However, his transfusion requirement is very stable. So we have not done we had not done anything because of the panagglutinin, because the transfusion requirement was very stable. In October of 2016, he developed jaundice despite the steady transfusion requirement, and actually at that point started to drop his hemoglobin from his stable baseline of about 110. So because he works full time and prefers to come for weekly, we tend to transfuse him at 110. What we then noticed was that with the jaundice, his transfusion requirement was going higher, and we were struggling to maintain his hemoglobin, and the bilirubinemia was worsening. And a diagnosis at that point was made that he has autoimmune hemolytic anemia. So a recurrence. So this is what happened with his hemoglobin. So this is his previous hemoglobin, where he runs a steady hemoglobin of around about 110 most of the time. And this is when he developed his jaundice episode. and his hemoglobin was just continuously dropping. And what you can see here is that he previously was running 120, and then around about July time, he'd started to drop his hemoglobin and was consistently dropping his hemoglobin down much faster than he would. And although we noticed the bilirubinemia in October, he actually had been dropping his hemoglobin, although it was, you know, it was still between 90 and 100 most of the time. It wasn't at a level where alarm bells would have triggered, but it was enough for him at that point for us to notice that there was a problem. He was then given IVIG and steroids, and what you can see is that his hemoglobin gets better, and he then continues with high dose steroids despite him being an insulin dependent diabetic, and we take a very long time. So if you look here, if you ordinarily drop, now or normally with autoimmune hemolytic anemia, we drop the steroids fairly quickly for the majority of people, but in his case, we just simply couldn't. And so we continued, and this is March now, this is 6 months after diagnosis. He's continuing on high dose steroids with a very, very slow tailing off of his steroids and a slightly more rigorous management of his insulin dependent diabetes. And it took, in fact, we stopped the steroids in around about September time of 2017. But if you look at what happened with his transfusion requirement, in 2016, he went to 9 units, 2017, 101 units, and then he's back down in 2018 to his baseline doses. And in fact, he was incredibly borderline from our point of view for us switching him over to rituximab. And we were, you know, if we hadn't seen this pattern of consistently improving pre-transfusion hemoglobins, he was highly likely to have been given rituximab at that point. But we managed him on this occasion with just steroids. And this is not the first patient, this is the 3rd or 4th patient that I've seen who developed very severe hemolytic anemia with thalassaemia major. And the answer is to really push hard with standard autoimmune hemolytic anemia therapy, but to be very, very careful around steroid reduction. Otherwise, you'll end up with a relapse.
Shah, thank you very much indeed for a very comprehensive description of the needs of blood transfusion in some of the complicated cases or the ones that bring about challenges to the transfusionist. I'm sure you come up very often with such challenges. Can we see some of the questions, Roy? Yes, I think that there was a slide by Professor Politis that was referring to the majority of some of them of the mistake in the hemovigilance program attributed to the errors. And somebody is asking to the human error. And a doctor is asking, can you be more precisely in what kind of errors you are referring to? What kind of human errors you are referring to? Maybe if Dr. Shah can hear us and we can hear you, Farah. I think it's in the short reports that some of the mistakes are human errors. Can you let us know what kind of errors?
Yeah, so I'm very happy to talk about that. The short report's been running in the UK for a very long time.
Yeah.
Human errors can be things like taking blood from the wrong patient, pre-labeling tubes happens frequently. So if you pre-labeled a tube and then taken a patient's blood sample, but it's a different patient, then the laboratory has problems. And that can actually result in the wrong blood being matched for patients. And it's a very common error that can happen. You can get laboratory errors because of equipment, because of samples being loaded incorrectly, portering errors where porters can collect the wrong blood for the patient. I mean, one of our patients, not a thalassaemia patient, but one of our patients actually died from a porter collecting a wrong unit of blood the anaesthetist putting up the unit of blood very quickly without having time to check that the unit of blood belonged to the patient, just assuming that the blood that had been bought was for the right patient. And the patient started to bleed during surgery. This happened many, many years ago, but human errors are very, very common and easy mistakes to make. The whole process from the sampling of blood all the way down to administration is prone to human error.
That's why we have to have very strict monitoring and sort of standards and procedures, but okay, it does happen. So human error, Dr. Farooq Shah referred to the identity matching mostly with reference to human error. And there is another doctor asking Dr. Shah whether in the last case that you were describing about the thalassemia major difficult case, did you use or did you think of using irradiated blood unit?
It wouldn't have made any difference. I mean, there's no evidence at all that irradiation of blood is going to reduce autoimmune hemolytic anemia at all. Mm-hmm. So the answer is no, we didn't. Clearly, if he'd ended up needing more intensive treatment, then we may have needed to think about irradiation. But generally, by and large, we don't use irradiated blood for autoimmune hemolysis.
Dr. Shah, during the COVID pandemic, we have heard from our patients that we were in constant communication that there was no real challenge in the blood adequacy.
Yeah.
How is this achieved? I mean, we went through the protocols of your transfusion system, and we know that you have some policies of reserve, red blood cell reserve, 6-day reserves, and other such policies. So that was, in your opinion, managed very well during the pandemic?
Yeah, I mean, we're very fortunate that the National Blood Service has direct communication with all of the hospital transfusion laboratories, and they did, prior to COVID lockdown, and even during COVID lockdown, they did public health awareness campaigns. We actually did not at any point even go into an amber stock issue. I mean, you know, we were green the whole way through, and so we were very fortunate, and our committed donors for, you know, for example, like with our autoimmune hemolytic anemia patient.
Mm-hmm.
What about Greece?
Antibodies.
Yeah.
Our donors who were donating regularly for those sort of patients where they've got multiple alloantibodies, we had no problem getting blood for them.
That's a privilege indeed, because in most of the countries that we were recording, blood shortage was a major issue, I think including Greece. How about, it does appear, Dr. Shah, that the weight falls on your shoulders since we have a technical problem with our friend Politis. How about the transfusion safety for pediatric patients? Can you differentiate, or is there any special challenges?
No, there isn't. It's actually the same. The transfusion safety processes that are followed. I think it's unwise to have different processes for adults versus children. I mean, this should be managed on a, you know, the whole process needs to be safe, regardless of whether you're a child or an adult. And I think that that's a real issue. One of the doctors from Algeria has said, asked me, did we consider using IV erythropoietin? So erythropoietin for autoimmune hemolysis, I would avoid in thalassemia, because I'd be mainly worried about worsening extramedullary hematopoiesis and pushing the erythropoietic drive further in the wrong direction. So the answer would be that we would go with steroids, and then further more severe immunosuppression rather than creating more erythropoietic drive. So rituximab and other therapies would be the next option.
Okay, so if there is no other question.
More than 10%.
Sorry,
yes, 10% of our patients get nose bleeding at the time of transfusion.
Yeah.
That is really interesting. I have to say that I've never seen that. And I think that that definitely requires further research. I certainly have heard one of my...
10% των ασθενών μας τρέχει νου του ζέμανα.
Ah, really? So that may be random incidents or...
Because it says 10%. I have heard a colleague from Pakistan tell me about bleeding in her population of patients. And I think that they need proper clotting screens, because we have to remember that there are multiple factors that can cause bleeding. Certainly in Iranian patients and in other countries, you may have platelet function defects, you may have co-inheritance or factor 11 deficiency. Some of our patients, about 8 or 9 of our patients have got factor 11 deficiency in addition to thalassaemia, so they could potentially bleed in that presence. And very severe iron overload, if you've got very, very severe iron overload, you can get von Willebrand's, acquired von Willebrand's deficiency because of the severity of the iron overload. So I think, you know, the patients need formal assessment to see what the cause is for them bleeding individually.
The other question is, I know that multiple wash-packed red blood cell transfusion can be expensive, but I want to know if that's the most safest work for transfusion for thalassemia major. So they are discussing the, but of course, washed blood is not the first recommendation. I'm sure, is he talking about pre-transfusion filtration?
So
a patient is asking about multiple wash-packed red blood cell, probably in her or in his country. This is the policy that is being used.
Yeah, so again, I would only use washed red blood cells as a final step. And if you can leukodeplete at source, then your risk of transfusion reactions goes down very, very, very significantly. I mean, it's, you know, it's been transformational since we've gone to leukodepletion. You know, I don't see, when as a junior doctor, I used to be all the time on the wards having to deal with febrile non-hemolytic transfusion reactions, and we don't see those things anymore. Washed red cells are expensive. They can only last for 24 hours after you've washed them. It's a very precious resource. And then if you fail the washed, you know, if you develop problems, then what do you do after that? Washed red cells doesn't get rid of infections, doesn't get rid of a whole host of other concerns. And I would use those as my final stop, but leukodeplete at source would be better. I think most transfusions would say the same, leukodeplete at source if you can.
Okay, so thank you very much. I think that we need to end the webinar. I am sure my friend Dina Bolidi is very, very upset with her technology, but don't worry, the presentation was very comprehensive. Any questions will be sent to us and will be sent to you for further responses, and your presentations will be uploaded. Do not worry at all. This is how technology is. Let me thank you very much, Dina. Thank you, Farah, so much. And thank Gadia Belidi, who is with us all the time. She's the scientific educator of Thalassaemia International Federation, responsible and administrator of the electronic platform. Gadia, if you've got something to add, otherwise we will thank everyone and close. So Gadia has nothing to say. Thank you so much. And only our gratefulness and a deep appreciation on behalf of Thalassaemia International Federation. Have a nice afternoon. Thank you very much.
Hello, everyone. Sorry, I couldn't unmute my...
Gadia is a scientific educator, just to say hello, yes?
Please promote our courses. We have a patients course and courses for healthcare professionals. Please promote them to your patients and to your colleagues to sign up. They are free of charge. They have been reviewed by international experts. So we need your support in promoting these 2 courses.
Thank you so much, Kadia. You said something that I should have said from the beginning. A very, very special request to you to pass on this information to your colleagues, healthcare professionals, and very much to your patients to come and join us. And please, any comments or recommendations or suggestions are more than welcome to
Yes,
go on improving our platform. Thank you. Thank you, Kadia.
Thank you.